In this video, we are discussing a framework on how to choose the correct squat for your patients. This framework is to help patients improve their mobility as well as get them out of pain. Let's talk about it. So when it comes to squatting, we all know that all squats are not created equal and there are tons of variations out there. But how do we get it really specific for our patient in a way that improves their mobility and gets them out of pain? It comes down to this. The first thing we need to understand is their structure. All of our patients are going to have an inherent bias. Now, I talk about this more in the Clinical Coaching Foundations course, but for this video's purpose, let's think of it as their COM, center of mass. Each one of our patients are either going to be biased towards having an anterior center of mass or a posterior center of mass. Those that can control it in the right way typically aren't going to have pain. But the ones that are at your office and your clinic and your gyms looking to get out of pain, increase mobility, and move better, these are the ones that can't control it. So let's walk through each one. We have anterior and we have posterior. Who are these people? Anterior, these are the ones that have the big butt syndrome, the butts that stick out, the rib cages that flare out, the ones that live in a ton of extension. That is our anterior. Posterior, these are the no butt syndromes, the exact opposite. Think of more hunched over, the tailbone tucks under, we have a more rounded posture, and it gives the appearance that the patient doesn't have a butt, right? So, center of mass, anterior pelvic tilt, extension. Posterior pelvic tilt, more flexion. So, if we want to not change our patients, then we choose squat variations that give them more of the same thing. So for an anterior type of bias, we would give them anterior type squats. For posterior, it would be posterior. That's not the purpose of this video though. The purpose of this is to understand that once we start to give them what they don't have, they'll start to feel better. Not only will they start to feel better, they'll start to improve their range of motion and increase their performance and get out of pain. So let's walk through each example to really comprehend the why, and then let's jump into demonstrations and understand the application. So what do we want to do from an anterior center of mass? We want to start to shift them back. So in green, we're going to write posterior COM. We essentially want to give them what they don't have, aka move them towards the other end of the movement spectrum. Posterior center of mass. How do we do that when we're thinking about squats? Two things, pelvis and rib cage. They both need to move back. So how do we do that from the pelvis perspective? We are going to elevate heels. And we'll talk about that when we go through our application component. From the rib cage, we're going to reach. So we'll write R, reach. So if someone comes in with an anterior pelvic tilt extension-based pattern that complains of pain and we want to give them squats, we're thinking, how do we get them back? From a pelvis perspective, we elevate the heels, aka posterior pelvic tilt, and from the ribs, we add in reaching. Great. Now, let's add a line here. We'll go to our posterior. Now, if you want to keep your posterior type center of mass person in their current pattern, pain, that's what you'd want to do. But that's not what we want from this video, right? So for the posterior center of mass, we are trying to shift them in the anterior direction. So we're changing their center of mass posteriorly to more anteriorly. From a pelvis perspective, I'm just going to write floor. You can elevate the toes if you want. From a squatting perspective, might not be the best option. Depends on the patient in front of you. And from a rib cage perspective, we are looking to elevate now. So we are looking to get them in more of a position where the rib cage can actually elevate. So as you can start to see, you can get crazy strategic with the way that you choose a squat that's based off your patient's structure to change their center of mass, to change their pattern. Changing a pattern is what's going to get someone out of pain. Now, let's check out the examples for each one of these exercises. So let's start with our anterior center of mass. These are the patients that live with a wide infrasternal angle, an anterior pelvic tilt, and an extension. Now remember, if we want to keep them in this pattern, usually the one that's causing them pain, then we'll give them like a barbell back squat and they'll stay in their pattern. They'll get crazy strong, but probably get crazy dysfunctional. Now the point of this video is to improve mobility, decrease pain. So as we talked about, we need to get them towards the other end of the center of mass. Now that being said, I'm not saying they need to be here, right? They just need to get out of here and get a little bit more here. That's where this exercise comes in. So let's start at the pelvis like we did on the whiteboard. When we go on a slant board, where does the center of mass get displaced? Here, if I just stay here, I'm getting pushed forward. So if we're in an anterior pelvic tilt, we really get pushed forward. So what happens as we step on this slant board? Our patients get a little bit of compression posteriorly to allow for a slight posterior pelvic tilt. When they're in their normal anterior tilt, there's too much eccentric tissue back here, eccentric posterior pelvis muscles. So just by being on here, they get a little bit concentric. That is going to work to get that pelvis to move a little bit more posteriorly. Second, I like using a dumbbell, a water bottle, anything that allows them to be in a 90-90 position, 90 degrees elbow flexion, 90 degrees shoulder flexion. And I like this for two reasons. One, it allows them to reach to depress the rib cage. Two, this allows them to see their arms, which is now a representation of their spine. So if they're going down and all of a sudden they see their arms start to go up, they know they're going into extension. If they see themselves really starting to go down and they really see visually that dumbbell come down, then they're going through too much flexion. So it's a really good reference for patients. Once they get this, they're in that slight posterior pelvic tilt relatively naturally. Elbows stay in, reach. Then they're learning, where do I need to go to where I can still hold that? If they go here and they start to dump, great. Go to where they can control that new position. Get them really proficient at building tolerance in a position that is completely foreign to them. This is how we strategically start to utilize squats. Now let's talk about our posterior center of mass patients. These are the ones that have a narrow infrasternal angle, a posterior pelvic tilt, and bias more flexion. Now, I do want to preface this and say that we're going over a barbell back squat, and I actually don't really like barbell back squats, but it brings up a really good point. When things are done in a strategic way to have a specific outcome for a patient, I think any exercise is 100% correct. It's when we use a barbell squat for everyone and think we're going to get a different outcome. What we're talking about here is using exercise as a tool to change someone's center of mass because they understand how to control a new position to improve their mobility and decrease pain. How does it work? Well, remember, these types of people like being here. The second we go into this position, I am now biased into more extension. Now, for our anterior center of mass individuals, this is an easy way to drive them into more dysfunction, as we previously stated. But now that we're thinking from a structural standpoint, how do I utilize exercise to change my patient's pattern? That's where this becomes powerful. So from here, all we're cueing them to do is to push the knees forward as they sit down. And what you're going to find is there's a little bit more of a horizontal trajectory compared to that verticality. But what's going on there from a pelvis perspective? Well, we don't have an elevated heels position, right? So we're not getting shoved in that posterior pelvic tilt. You could go to a toes elevated, but honestly, probably just want to stay on the ground for these individuals. From a pelvis perspective, as we push back, We're working on lengthening and putting that pelvis through eccentric activity, which is normally not used to. It's normally used to being completely locked down. So it's a little bit of a horizontal trajectory for a very specific reason. From a rib cage perspective, just going in this position starts to elevate the rib cage a little bit. So again, the pelvis and the rib cage are going through different ranges of motion than they're used to. Like I said, I don't use barbell back squats a lot, but when things are done strategically, you can do things and have confidence because you know exactly why you're doing them.